Hello, everybody. Welcome to Grand Rounds on Monday, November 1st. We are happy to have you all with us to talk about a very important topic, talk about cardio-oncology inpatient consults. And to do that, we're joined by Dr. Gagan Sahni, who you may remember was a cardiology fellow and chief fellow here at Beth Israel. Since then, she spent some time at Metropolitan Hospital as the CCU director and a winner of a number of teaching awards. She's been back at Mount Sinai Uptown since 2010, where she now serves as the director of the cardiology consult service and the director of the first cardio-oncology consult service at Mount Sinai, which was established in May of 2013. And we are delighted to have her with us. Dr. Sahni.
Thank you, Dr. Weissman. So I'm running the cardio-oncology program and cardiology consults, both at Mount Sinai. So I thought I'll combine this year's grand rounds and make it relevant for all the residents and house staff that will be seeing this very interesting combination of cardiology conundrums and questions on your oncology patients while you're doing inpatient consults. So at least I have no disclosures. And so what we'll try to cover today is basically the need for cardio-oncology, why we exactly having this lecture, so that we're attuned to the problems that we will be seeing in our inpatients. And we'll try to challenge some of the inpatient cardiotoxicities, especially CHF from chemotherapy and immunotherapy. We'll talk about a little bit about MI and acute coronary syndromes in cancer patients and why they're different from the rest of our patients. Of course, venous thromboembolism, DVTs, and PEs in cancer patients and drugs of choice as to where the data stands today. A few arrhythmias, such as atrial fibrillation in our cancer patients, and a few cardiac emergencies, such as pericardial tamponade. The reason why we need to have this talk today and why I designed it around inpatient is pretty much that cardio-oncology. So just as a disclaimer, I'm not an oncologist, I'm a cardiologist who sees cancer patients. And so it's actually an offshoot of cardiology. And the reason why this specialty has come afore and is a special specialty by itself is that as of now, there are about 5% of the US population has 17 million cancer survivors existing in this country today. And by 2030, that number would have burdened up to 22 million. And why is that important? The importance is not that we are saving so many people and they have such a good cancer survival, but because they will live not only for 5 years more on an average, but if these patients who survived cancer were greater than age of 50, then 50% of the men and 40% of these cancer survivors are going to, in the remainder of their life, develop some cardiovascular disease, not because there is an overlap between cancer and heart disease risk factors, but because of the therapies that we use in our cancer patients. Not just the adults, but it's our children as well, our childhood cancer survivors. We know that luckily, and the number is even better than the adults, that 80% of children and adolescents who were treated for cancer are going to go into adulthood as long-term survivors, and they're going to be our patients. And approximately last year, there were about 500,000 of pediatric cancer survivors. And we know from the childhood cancer survivor study that the cardiac mortality in these patients, even though they survive their cancer, is actually 7-fold higher and about a 15-fold chance of them developing heart failure from the cardiotoxic chemo and radiation that they receive for their childhood malignancies. And the third reason why we need to have this talk is because the evolution of this fabulous field of cardio-oncology has really accelerated at such a speed that in 1966, I guess we're well before the majority of this target audience was even born, but when when anthracyclines were first discovered in the 1960s, that's all we knew about the cardiac effects of any chemotherapy, right? And we started to understand that this is dose dependent. We decided that, yes, it causes heart failure. And in the 1990s, and mostly from the data we saw from anthracyclines and then Trastuzumab, when we started using it for HER2-positive breast cancers, there were about 90 publications in PubMed in the late 1990s. And now we've burgeoned to a point where in 2014, not only were there about 812 PubMed citations of cardio-oncology, which is well beyond about 10,000 or so at this point, but in 2016, we established about 37 cardio-oncology clinics in the US, and proud to say that Mount Sinai was among the premier cardio-oncology programs in the country. And of course, now we've gone forward to not just having a cardio-oncology program, but we are among the 51% of ACGME fellowships that have a dedicated cardio-oncology service and survivorship program. And if people, including cardiology fellows, are interested in cardio-oncology, there are actually 8 US fellowship programs, and it's a 1-year fellowship program just dedicated to cardio-oncology. And as of the COCAT competencies, the cardio-oncology training is now part of the ambulatory as well as inpatient requirement for a cardiology fellowship. And so let's delve right in, and I'll try to cover some of the mechanisms, not all, of cardiotoxicity and what you will be seeing in your inpatient consults. And really, when we talk about cardiotoxicity, I know that anthracyclines and heart failure springs to mind because that's one of the most common things that we've been hearing since the 1960s. But really, there's a whole Pandora's box of cardiotoxicity ranging from hypertension to angina, acute coronary syndrome, Takotsubo's, stroke, peripheral arterial disease, pulmonary hypertension, and venous thromboembolism. And we'll try to cover a few of them in the scope of this talk. So let's delve right into the kind of consults that you're going to see, right? And I put this fancy topic on top called CTRCD. So we're away from the paradigm where we call heart failure due to chemotherapy, which could be anthracyclines or anything else. And we know that we treat different cancers with everything ranging from chemo to radiation to immunotherapy now. And so no longer can we call it chemotherapy-induced cardiomyopathy. And so the ASC, which is the American Society of Echocardiography, has given this elegant definition for cancer therapeutics. So it involves everything, including chemo and radiation and immunotherapy related cardiac dysfunction, but because not everything is systolic heart failure. So let's start with Miss J, who's a 58-year-old lady with history of HER2 positive metastatic right breast cancer. And she had an echocardiogram. So as you might be familiar with, the Trastuzumab is the drug of choice to be used in HER2 positive breast cancer. And with this potential cardiotoxicity, everybody gets a baseline transthoracic echo, which she did. And even if in this audience, if you don't know how to see an echo, that's all right. This is a 4-chamber view, and this is the left ventricle, and it looks like it's squeezing pretty well. So it was read as a normal ejection fraction of 58%, and I think across the Mount Sinai labs, the normal number is above 55. And so she had normal LVEF of 58%, and then there's something called a GLS, and I'm going to touch on this because you're going to see a lot of your reports at Main Sinai as well as at downtown Mount Sinai BI, that you will see another number next to the LVEF called the GLS, and it says, hey, the GLS is minus 20%, and may or may not include a bullseye map like this, okay? So going on to the same lady, Miss J, she gets 4 cycles, as I said, of doxorubicin as a neoadjuvant therapy. What does neoadjuvant mean? It means prior to her breast cancer surgery. So when we give all the therapeutics prior to the surgery, it's called neoadjuvant therapy. And this was basically followed by the Trastuzumab or Herceptin that you guys are familiar with post doxorubicin. And 1 month after completion of doxorubicin, she starts having cardiac symptoms, including palpitations, sinus tachycardia. And then the oncologist gets a repeat transthoracic echo. And now the ejection fraction is mentioned to be 55. So remember that normal is 55 and above. So sort of hanging around the normal, but this lovely second number called the GLS, or the global longitudinal strain, as I mentioned earlier, is now at minus 14% from minus 18%, if you remember. And this bullseye map, from being a lovely plum red, has started changing colors, and the numbers have gone down from minus 20 to minus 10, minus 12 in a patchy distribution. And the report states that the GLS has declined. So what are you going to do with this report? And more importantly, the consult questions are, hey, is this really cardiotoxicity from the anthracyclines and then the trastuzumab that the patient received? What is the CTRCD that Dr. Sahni is talking about? Why do we need this number called GLS in addition to the LV ejection fraction? And if we are getting this cardiology consult, what am I supposed to say? Can we continue the next cycle of the ongoing Trastuzumab, or shall I call it cardiotoxicity and stop it? And you did mention that the ejection fraction, it came down to 55%. Does that mean that the ejection fraction is decline? And when shall I get the next echo? And if there is a decline, is this reversible and how can I prevent it? So I'll try to answer all these big questions with this context. So don't keep calm and phone a friend, and that friend is me, or maybe an expert with all these expert consensus documents from ASC to Mayo Clinic, the 2016 ESC position paper on cardiotoxicities, which are probably the current existing guidelines that might help you. So anyway, while you're reading all these guidelines, the patient, unfortunately, and you're figuring things out, and the patient keeps getting Trastuzumab 3 months later. And again, I won't do a back-to-back, but as you can see, if you remember from the first echo, the ejection fraction, again, in that 4-chamber view, the squeezing or the contraction or the thickening of the LV does not seem to be as robust as the prior echo. So that's not looking good. And now the echo reports that the LV ejection fraction is now 35 to 40%. And so now you're in a real bind to answer those questions. And luckily, some expert consensus documents, like the one from the American Society of Echocardiography in 2014, gave us the definition of this fancy CTRCD, which is cancer therapeutics related cardiac dysfunction. And this is important, and stay with me, that to call any therapy for cancer as causing cardiotoxicity or causing a related cardiac dysfunction, you have to have both of these two. You have to have a decrease in the patient's ejection fraction by greater than 10% over the patient's baseline to a value of 55% or less, or whatever the lower limit of normal in your lab is. So your lab, our lab, uses 55 as a normal. So going back to our patient, yes, the EF declined, quote unquote, from 58 to 55, but it's not a decrease of greater than 10% initially. But the second one was a 40% ejection fraction. So that was a decrease in ejection fraction of more than 10%. And it was to a value of less than 55%. So yes, this patient has undergone CTRCD, or the cancer therapeutic that we used in this case, including Anthracycline and Trastuzumab, did cause a cardiac dysfunction. So how do these two medications that we commonly use for breast cancer, which is doxorubicin followed by Trastuzumab, how do these work in making the ejection fraction come down? How are they cardiotoxic? And so stay with me on this busy basic science slide. So doxorubicin, as we know it, can enter into a cardiac myocyte. So this is right outside a myocyte. And it basically enters a cardiac myocyte by combining with a ferrous moiety and becoming a doxoferrous combination, which is the bad guy, not only because it can now enter the cell membrane of the myocyte through lipid peroxidation, but once it enters inside our cardiac myocyte, it sets off a whole cascade of a doxy-semiquinone form, which is a toxic form of the doxorubicin, which will then cause mitochondrial dysfunction. It will enter into the sarcoplasmic reticulum and cause lipid peroxidation. And it will set off a whole bunch of free oxygen radicals that are going to cause damage to the contractile apparatus, to the mitochondria and the sarcoplasmic reticulum. And the way it does that is not just with the doxosemiquinone form, but it also acts through this molecule called Topoisomerase 2. So there are two kinds of molecules. There's Topoiso 1, which is in our cancer cells, which is targeted by the doxor to kill the cancer cells. And there's Topo 2, which is actually normally present inside a cardiac myocyte. And it does a pretty good job. We need it for cellular transcription and replication. But when the doxo attaches to this, it becomes a very bad molecule that will set off this entire cascade of harming and killing our myocytes through free oxygen species, through mitochondrial dysfunction, through affecting the contractile apparatus. Not just this, it also depends on the amount of anthracyclines that we're using. So if we stick to a dose of less than 300 milligram per meter square, and this is for doxorubicin, and remember, this is a lifetime exposure. So if you have your childhood survivors that are basically getting this chemo as a child, and then you're giving it to them, say, for a second malignancy in adulthood, the clock starts with their initial exposure. So you have to start calculating the amount of doxorubicin they got cumulatively, and the higher the dose, the chances of them developing CTRCD would be much higher, up to 50% at higher doses, which we unfortunately do not use anymore. And not just that, but not all anthracyclines are created equal. So if we take doxorubicin as the big gun causing 100% cardiotoxicity in its higher doses, the other anthracyclines such as daunorubicin, idarubicin, and epirubicin are much less cardiotoxic compared to it. So it becomes important if we're dealing with CTRCD and we need alternatives. So going back to our story about the Topo 2B, here is how Topo 2B acts and how we can actually circumvent to protect hearts from anthracycline cardiotoxicity. So this guy here is a Topo 2B molecule, and it's got a normal job of basically unfolding our DNA, which is required for normal replication and transcription. The problem becomes when these anthracycline molecules now combine to the Topo 2B, and this combination of anthracyclines and Topo 2B, if you follow my marker here, now becomes the bad guy, which will set off reactive oxygen species causing DNA double-stranded breaks, mitochondrial dysfunction, which will eventually lead to apoptosis and cell death. So there are molecules which not only, and this substance is called dexroxazone, which we use as a cardioprotectant in preventing anthracycline cardiotoxicity for patients who had a higher dose of anthracyclines or who are getting second exposure of anthracyclines. And what it does is it basically acts as an insurance policy. It attaches to the Topo 2B molecule, and as a competitive inhibitor, it prevents the anthracycline molecules from combining to it. As a result of it, this unholy cascade is not going to happen anymore, and the Topo 2B just keeps doing what it's supposed to do and not cause DNA double-stranded breaks and cell death. So we actually use dexroxazone as a cardioprotective, and that's why it's so important to understand how drugs like anthracyclines act in causing CTRCD or cardiotoxicity. And in fact, we see it in clinical data that if we combine doxorubicin with dexroxazone as a cardioprotectant, the same dose of doxorubicin, which would have been 7 times as more cardiotoxic, now becomes 1/7 as cardiotoxic, and compared to other anthracyclines as well, if you use it as a combination. So the question is, well, why don't we just all comers give dexroxazone to everybody and anybody undergoing anthracycline? And the reason being that, yes, there is a great reduction in anthracycline cardiotoxicity with a relative reduction of it up to 79%. But in earlier trials, not everything comes without its baggage. And it has been shown in some studies, smaller studies, to cause myelosuppression, secondary leukemias, and reduced drug efficacy. And that's why in the US, the FDA has approved it only for patients who already received a lifetime dose of 300 milligrams per meter square and need additional anthracyclines. But we keep it off label for patients that already have cardiotoxicity, and we really don't have any alternatives to anthracyclines. What about trastuzumab? Is that a bad guy like anthracyclines? Is Topo 2B the mechanism of action? The answer is no. The way trastuzumab acts is that it basically combines to HER2 receptors and HER2 breast cancer. The problem is that it's not just the breast cancer cells that have HER2 receptors. Our hearts have HER2 receptors as well, which is a part of protective pathways to protect the heart. So for example, so it's acting on the HER2 receptors, which we wanted to destroy the tumor cells. But as a result of which, HER2 receptors in the cardiac myocyte also get upregulated as a part of cellular regeneration and protection. But if HER2 is being targeted and trastuzumab is being used, a lot of these HER2 receptors now get upregulated, and the trastuzumab goes and attaches to these extra HER2 receptors on the cardiac myocyte, inhibiting the protective mechanism that is responsible for the cardiac myocytes recovering from anthracyclines. So the problem is not just the trastuzumab. The problem is that trastuzumab is blocking the HER2 regenerative pathways that our hearts need to get over reactive oxygen species from prior anthracycline receptors. And that's why, and this is something that gets asked in your boards and questions a lot of times, there are different kinds of cardiotoxicity. So drugs such as doxorubicin cause myocyte cell death. They are dose related. And if we actually see them under a electron microscope, we will see vacuolation and cell death, versus type 2 cardiotoxicity causes myocyte dysfunction without cell death, and it is not dose related. So trastuzumab by itself is not a bad guy, but drugs such as anthracyclines, being type 1 cardiotoxic, actually cause irreversible cardiac cell death. And isolated, and we know from clinical data as well, not just electron microscope studies, that isolated trastuzumab cardiotoxicity without anthracyclines is actually very rare, and it basically is under 5%, mostly 3%, and mostly asymptomatic drops in LVF without overt heart failure. And in fact, we have studied in 2 trials, which were done recently, in the Safe Heart trial and the Scholar trial, where we actually took patients with borderline moderate LV dysfunction having a known ejection fraction of 40 to 49% in the Safe Heart trial and 40 to 54% in the Scholar trial. Of course, all of them were very well treated with ACE inhibitors, ARBs, and beta blockers. And we saw that 90% of these patients in both the studies were able to get a full year of trastuzumab without a significant drop in the LVEF, and only 10% of them had a further drop or clinical heart failure. So this lets us to know that trastuzumab, being a type 2 agent, is a much safer drug to tolerate, provided you are on good medical therapy and you're following them closely. And remember, you can't just say as a consultant, okay, trastuzumab is bad or doxorubicin is bad, because a lot of times the impact of holding these trastuzumab and these therapies could lead to a cancer recurrent survival, which is compromised. And so the Mayo Clinic and the ESMO guidelines currently recommend, so how often do we get echoes on patients undergoing anthracycline therapy? Well, you get a baseline one, and since it is dose dependent in type 1 agents such as doxorubicin, we repeat an echocardiogram at every increase in dose above 300 milligrams per meter square. And every time you escalate by 15 milligrams per meter square, you basically have to reassess with a new ejection fraction. And as I said, because it's irreversible, if there's a drop in LVEF by more than 10% to a value of the lower limit of normal for your lab, Mayo Clinic uses 50% as normal, we use 55. So if it meets the definition of CTRCD, you stop therapy. And if it is really a significant decline, you really have to have a conversation with your oncologist whether you want to continue anthracyclines in these patients. As for trastuzumab, the algorithm for imaging is a little bit different because it is reversible cardiac dysfunction and not cell death. You basically do echoes at every 12 weeks, every 3 months, you get an echo other than the baseline. And if there is a drop in LVEF to more than 10%, and here we have a little bit of leeway because we have Scholar and Safe Heart telling us it's okay to use trastuzumab in patients even with LVEF up to 40%. We actually don't interrupt therapy. We basically start them on ACE inhibitors and beta blockers. We just hold it temporarily, repeat the echo at 4 weeks, and basically resume therapy if the EFs are normal and they're not in clinical heart failure, and we're able to continue to give them therapy with trastuzumab. So coming back to the other question of what is GLS, and I know it's not an echo talk, and a lot of the audience is not a cardiology audience. So what is strain? Strain is actually a good word. It basically means our heart is contracting, and it's contracting in 4 different vectors: circumferentially, longitudinally, transversely, and radially. And we actually measure it. And so let me just concentrate on longitudinal strains. We actually, in our echo measurements, are able to measure how in the longitudinal axis is the heart contracting during systole. So for example, in diastole, each of our sarcomeres is 8 centimeters in the longitudinal axis, and it contracts to 6. That means it's straining or deforming in the longitudinal axis by 25%. So from 8 centimeter, it deforms or shortens to 6 centimeters. That's a deformation of 25%. It's a good deformation. So the more vigorous and healthy your myocyte is, the more your strain number will be a bigger number. And echo studies have shown that if this deformational strain is more than minus 18%, that's actually a good heart. And we put it in a bullseye map in all the segments of our heart, and we come to a composite number called the GLS, which is called the global longitudinal strain, which is the deformation of our myocytes, each one of them averaged out for the entire myocardium to spit out a number which, if above minus 18, shows a good strain in the longitudinal axis. But why are we so obsessed with this number, the GLS number? The reason being that we actually have good data of about 30 peer-reviewed studies that tells us that a decline in this GLS number actually occurs prior to a decline in LVEF when we're giving patients cardiotoxic chemotherapy or therapy like Trastuzumab and Anthracyclines. And this, if it drops by more than minus 15% over the patient's baseline, will predict future cardiotoxicity. So for example, in this patient that had a normal EF of 61 and a normal GLS of minus 20, remember above minus 18 is normal. And then the patient's therapy on Trastuzumab, EF is still good. It's not CTR-CD because the EF is still above 55 and didn't drop by more than 10%. But look, the GLS declined by more than 15% from minus 20 to minus 17. And lo and behold, we did nothing. So 12 months later, the GLS is still bad, but the ejection fraction now declines from 61 to 49%. So think of it as your crystal ball for future cardiotoxicity. Well, great. So this is what the ASC now tells us, that if you drop your ejection fraction by more than 10%, it will be cancer therapeutics related cardiotoxicity. But if you drop your GLS over 15% over the patient's baseline, that actually might be your crystal ball and indicates subclinical LV dysfunction. And you might be able to catch cardiotoxicity before CTR-CD actually develops. And so type 1 cardiotoxicity, which is from our anthracyclines, which is irreversible, the bad guy, can be actually followed by not just the ejection fraction, but by GLS and also by troponins, which can become positive if there's early cardiotoxicity, even prior to LVEF declining. And for type 2, which is Trastuzumab, again, if there is a drop in ejection fraction and GLS, you actually can ask for a cardiology consultation. Why? Because the question is, fine, we have this crystal ball of the GLS declining, but what do we do with this prediction? And so we actually have 2 trials now, including a recently concluded sucker trial, which basically said that if there is a decline in GLS without having been an ejection fraction decline, then we can, the arm that was treated with cardioprotective therapy, including ACE inhibitors and beta blockers, had a lesser decline in LVEF in the arm that was guided by GLS versus the arm where we just kept looking at the LV ejection fraction. And we know now that it's not just anthracyclines and our Trastuzumab antibodies that we basically causing LV dysfunction, but a whole slew of agents such as cyclophosphamide, of tyrosine kinase inhibitors, drugs that we use for multiple myeloma, including carfilzomib and bortezomib, that are involved in LV dysfunction. And really, it goes beyond type 1 and type 2 cardiotoxicity. And we've gone to like foldable phones now. We're no longer in those bulky phones that we used to use. And literally akin to that, we have all kinds of cardiotoxicity that are going beyond even the description of this page. But the one I really want to stress on is a few patients, and a lot of them from BI that we get transfers for, is the cardiac toxicity of immunotherapy that is replacing a lot of chemotherapy that we know today. And I would like to illustrate it with an example of a physician that we had at Mount Sinai with non-small cell cancer that was treated with this immune checkpoint inhibitor called pembrolizumab. and you might have heard of it in a lot of your patients. And he comes in with chest pain and shortness of breath with a troponin of 36 and new EKG changes. We rule out PE. His lung cancer has not progressed, so that's not the reason for his shortness of breath. We cath him for the troponin of 36 and they're normally coronaries, but lo and behold, his echo is showing a new decline in ejection fraction to 35%. And while we're doing the echo, the patient goes into complete heart block. And so the question is, what do we do here? Do we await? What is happening? Why did the ejection fraction go down so quickly with the troponin of 36? What shall we do? Should we get a cardiac MRI to confirm the diagnosis? Is echo enough? Shall we start steroids? And at what dose? How fast? And what exactly is happening? And so really, to answer this question, I want you to make you familiar with immune checkpoint inhibitors, which are pretty much the paradigm of a lot of malignancies nowadays. And it's not chemotherapy. It is basically acting on several receptors which the tumor cell is having that combines to, so whenever our natural body's immune mechanism is to fight the tumor cells. And the T cell combines to our tumor cells with different receptors, but the tumor cells are very smart and they have something called checkpoints. They are basically the lifelong insurance policy of the tumor cells that will combine to the T cells and prevent the T cells from phagocytosing them and killing them off. But the checkpoint inhibitor, this entire class of 11 drugs that are currently approved, basically breaks off the insurance policy of the tumor cells, lets our T cells attach to the tumor cells effectively, phagocytose them and kill them, which is what we wanted them to do in the first place. So basically, these are molecules that are letting our own immunity, our own T cells, kill the tumor cells. And it basically came into fore when our ex-president was treated for his brain cancer with a similar drug called pembrolizumab. So it's a designer drug, if you might call it so, and that's why President Jimmy Carter is still around today. And we really, the timeline of immunotherapy has now progressed to CAR T therapy and CRISPR, which is beyond the scope of this talk. But these immune checkpoint inhibitors have literally been studied in every malignancy from top to toe and go beyond even the scope of this slide. But comes with it its own slew. Remember, we're letting our own immunity attack the cancer cells. So what's the side effect and what's the collateral damage? Our body can be attacked by our own immunity as well. So it can literally cause everything from cerebritis to toeitis, that I say. But clearly, since I'm a cardio-oncologist and the topic today is what we're concerned with is the heart, immune-mediated myocarditis is one of the side effects of these checkpoint inhibitors. And really, when I saw Dr. Coleman, we had already data coming out from mortality studies in these checkpoint inhibitors that showed that they develop acute heart failure from immune-mediated myocarditis. So not anthracyclines through Topo 2B or Trastuzumab through HER2 receptors on the heart, but a completely different mechanism of action. And we've been contributing to a registry data with MSKCC as well as Mass General. And we've realized that this myocarditis is becoming more and more common. And it's in pre-marketing data, it was less than 1%. And now we're seeing more and more immune-mediated myocarditis up to 2%. And here are the registry take-home points that we've learned, that actually your echoes might be completely normal, right? So the echoes that I showed you for anthracyclines might be useless because their MRIs and the LVEF in these patients might actually be completely normal despite the myocarditis. But this mostly occurs in the first 3 months. It usually occurs when you use a combination of these PD-1 inhibitors, so 2 drugs instead of 1. And believe it or not, the best tools to pick up early myocarditis from these agents is troponin I and EKG. So we and our oncology colleagues try to get simple tools, troponin and EKG, cheap, easily accessible when they come in for the infusions, especially in the first 3 months. And the MRI will show myocarditis much later on. And the higher the troponin quartile, the worse their prognosis. And the most common EKG changes, especially prognostication-wise, is an increase in QRS duration, but it can pretty much vary from anywhere between QRS duration prolongation to complete heart block to ventricular arrhythmias. And actually, the echo might be in 60% of these patients who were completely normal. But remember the GLS that I showed you in the previous slides? Lower GLS, a drop in GLS with a preserved LVEF could be an early marker of immune-mediated myocarditis and also indicates worse prognosis. And the LGE, or the late gadolinium enhancement that we see classically in myocarditis, will be present only in about 50% of the cases, and it was not associated with worse outcomes. And the timing is a key. There's no point in rushing to an early MR in these patients, because it's only after the 5th day that MRI, if it has to turn positive, becomes positive. And believe it or not, vaccines such as flu vaccine were actually predictive, and not like the COVID vaccines, was actually protective in patients with immune checkpoint inhibitor myocarditis. And so what do we do? So if this patient had come in today, what would you do? Since it's immune mediated, you want to shut down the whole cascade of your body attacking its own heart, and you want to hit them with steroids. And the key here is almost like a STEMI, okay? The higher the dose of steroids that you hit them with, the better survival and less MACE. So really, the dose that you should be hitting in patients who you are suspecting immune checkpoint inhibitor cardiotoxicity should be methylprednisone in a dose of 1,000 milligrams a day for the first 3 days, followed by prednisone 1 to 2 mg per kg. The higher the doses you bombard them with, the better their MACE events will be. And if you give them a wimpy dose of steroids, their MACE could be as high as 66%. And so that's exactly what we did. We hit Dr. Coleman with a high dose of methylprednisone. His LVEF actually improved within the same admission. He did end up needing a pacemaker for his complete heart block from the myocarditis, but he was discharged home in good spirits. And if the steroids don't work, we do add other anti-inflammatory, other immunosuppressants such as mycophenolate or Cellcept, infliximab, tacrolimus, etc. And so the take-home message for immune checkpoint inhibitor cardiotoxicity and immune-mediated myocarditis is, please check the troponins and EKGs, especially in the first 3 months that they're undergoing therapy. And if they are presenting with abnormal EKGs, positive troponins, as fulminant as heart failure and heart block, like I showed you in Dr. Coleman's case, please call cardiology and stop them with high-dose steroids as soon as possible. Moving on, different chemos such as tyrosine kinase inhibitors. Again, the reason I'm showing you these slides is that not all drugs, including immunotherapy and checkpoint inhibitors and TKIs, are created equal. We have to understand the mechanism behind them, because if we are going to treat the cardiotoxicities to prevent them, we have to understand how they act. And literally the pathways for all of these drugs is very different. And so, and going beyond what the mechanisms are, also remember that our cancer patients have a lot of Takotsubo. So you must be familiar with stress cardiomyopathy, or a classic Takotsubo is cardiomyopathy, where the LV balloons up in the apical segments and looks like this Takotsubo's octopus pod. And we know from data in cancer patients that Takotsubo itself, even without any underlying cardiotoxicity directly from their immunotherapy or chemotherapy, that we might be dealing with an increased incidence of Takotsubos in cancer patients. And actually, in registry data, it could be seen in as many as 29%, 1/3 of the patients. And that might be a separate or a concomitant pathogenesis behind cardiac dysfunction in our patients with chemo. And also, of course, we do know ACE inhibitors, beta blockers are the standard treatment for CTRCT or heart failure in any of these patients. But do keep in mind, keep your PDR handy, because a lot of the drugs that we use in cardiovascular disease might have a drug interaction with antineoplastic agents. So keep your micromedics handy. Jumping on to another topic, which is MIs and ACS, a very common one that we see is with 5-FU. So we have a patient who was on FOLFOX, which contains 5-FU, which is very commonly known to trigger off acute coronary syndromes. And so he was given his several cycles of FOLFOX, ends up having a non-STEMI after the 3rd cycle, ends up getting a cath and bare metal stents to 2 of his arteries, and gets a re-challenge of 5-FU after we refastorize them. So I've given this example as an illustration to bring forth, hey, how often does 5-FU cause MIs, and what do we do with it? And if they do develop real NSTEMIs, do they have underlying CADs, and what do we do with it? And also remember that not all cardiotoxicity with 5-FU is just chest pain and acute coronary syndrome. We actually, in rare cases, do see malignant arrhythmias such as ventricular fibrillation, torsades. And so keep in mind when somebody's on 5-FU therapy. And so 5-FU acute cardiotoxicity ranges anywhere between, funnily enough, 0 to 34%. The reason being because the studies included a lot of just EKG changes or positive troponins without there actually being an NSTEMI. But if you really have to tease out the data, Probably the most cardiotoxic is the 48-hour infusion that we send our cancer patients home with. And if you want to say that, oh, the capecitabine or the Xeloda that we use for our patients might be a little less cardiotoxic because it's an oral drug, that's actually a misunderstanding, because the oral capecitabine might be equally, if not more, cardiotoxic compared to 5-FU. And really, the mechanism of action of any of these 5-FU containing compounds is not just vasospasm, but a direct toxicity to the myocardium by cardiotoxic metabolites such as fluoroacetate and fluorocitrate. And what do? Well, you treat them for primary and secondary prevention with nitrates, beta blockers, and calcium channel blockers, and you want to try to avoid re-challenge. But if you literally do not have any choice and 5-FU is their best choice, be cautious. As I said, do just the bolus treatment. So as I said, the single bolus of 5-FU has a less than 3% vasospasm and cardiotoxicity, and the 48-hour infusion is probably the most cardiotoxic. So you probably want to re-challenge them with a bolus and not the home 48-hour infusions. And if they develop malignant ventricular arrhythmias or acute coronary syndromes, there is an antidote for acute 5-FU cardiotoxicity, the substance called uridine triacetate, which you give, and it's a rule of 96. You basically give it to them in the first 96 hours. It's 20 doses total, and 96% of them will have acute reversal of their acute cardiotoxicities. And of course, you then jump onto acute alternative drugs if you actually develop 5-FU cardiotoxicity. What about other drugs? So there are other drugs that can cause acute cardiotoxicity in MIs. And so here's this patient who has a testicular cancer, and we basically give him a treatment of Beth, which is bleomycin, etoposide, and cisplatin. And then after his 9th cycle of Beth, he ends up getting a STEMI, and this is cath showing a left anterior descending acute thrombus. This filling defect here being an acute thrombus. So if you had to take a guess among B, E, and P, bleomycin, etoposide, and cisplatin, what would you blame as the cause of this gentleman's acute MI? And so since I'm unable to interact in Zoom, cisplatin actually causes acute thrombosis in up to 18% patients, including 10% being arterial, like in this case. And actually, it has not only an acute effect, but also a long-term effect of cardiotoxicity, where it causes accelerated atherosclerosis. So keep that in the mind when patients are coming with acute coronary syndrome. Go down the list of the chemo that could be a potential cause, including in this young 30-year-old gentleman with no other risk factors. And so the slew of chemo that causes ischemia and acute coronary syndrome ranges from 5-FU to cisplatin to a whole bunch of tyrosine kinase inhibitors, and you should be aware of these. And how is it different having an MI in a cancer patient versus any other patient having an MI? And here the difference is in response. And the response is from our side. We're so scared of treating anything in cancer patients that our cancer patients were half as likely to get cath, PCI, or CABG, and as a result of which their in-hospital mortality and their complication risk is twice as higher. And we've seen from the BERN PCI registry, and here's where we go wrong. We've learned from our BERN PCI registry that we should not be afraid of giving them stents, and we should not be bare metal stenting them. The reason being that the difference between cancer patients and non-cancer patients getting stents is that there is no difference if we give them a drug-eluting stent. There's no difference in cancer or non-cancer patients in ischemic events, which means that they do not close down their stents. There's no difference in stent thrombosis in these patients. The difference is in major bleeding. So the important thing in patients that we're stenting with acute coronary syndromes in cancer patients is give them the right stent and choose the duration of your dual antiplatelet therapy, because they're not going to close their stents and have stent thrombosis. They're going to bleed from your dual antiplatelet therapy. So you want to use the stents which will last longer and need the shortest duration of DAT, not needing the potent P2Y12 inhibitors such as tegaglicor and Effient, etc. You want to be trying to stick to ones that make you bleed less, such as clopidogrel, and minimize the use of DAPT as well as triple therapy. And remember that even if your cancer patients are thrombocytopenic with a platelet count of 20,000, it does not protect them from ACS. Do not think they're not having an ACS because they are thrombocytopenic. It is okay to use clopidogrel for platelet counts up to 30,000. And it's okay to use aspirin up till 10,000. My perfect personal comfort zone is 20,000. You want to avoid the potent P2Y12 inhibitors. And it's okay to cath them as well as PCI them. You can always give them platelet infusions and do your procedures. Remember, they are always coming in for platelet and blood transfusion with the oncologist anyway, so don't shy away from giving them the best treatments, including PCI and cath, if they need it. And you probably, obviously, don't want to jump the cabbage bandwagon, but do not be afraid of doing interventions for them. What about venous thromboembolism? So here is a 48-year-old lady who is having anthracycline for metastatic breast cancer. She has a Portin. This is her TE study that we do because we saw an abnormal shadow in her right atrium. And guess what? We see this huge mass here linked to her line there, her port there. And we don't know whether it's metastatic or not. We tried doing a 3D study as well as a bubble study. And then again, there's some penetrance of bubbles into this mass, but we're not sure. But it's such a huge mass that we actually do a small thoracotomy and take it out. Luckily, it was a thrombus. But the reason I'm showing you this is the question that we will commonly be asked is that what should we anticoagulate cancer patients with thrombi, right? VTE, whether they're intracardiac or DVTs or PEs. How do we anticoagulate our cancer patients? And what is causing their VTE and how should we treat this patient? And really, it's not just cancers that predispose them to increased thrombosis. A whole bunch of chemo that we use in our patients also causes thromboembolism, right? And not to mention that the less ambulatory they are, there's actually a risk score called a Corona score, which lets you know how high risk they are for VTE, depending on what kind of cancer they have, what is their leukocyte count, what is their hemoglobin, and what is their BMI. And all of this contributes to their risk of developing VTE. And so there are actually some cancers, such as pancreatic cancer and multiple myeloma, because of their high Corona risk scores, we actually, in some of these patients, in an ambulatory center, decide to anticoagulate them. And there have been 2 trials studying, Beth has studied apixaban and Sahni has studied rivaroxaban for thromboprophylaxis in these patients. And the result of both of these is, yes, using half dose of both of these anticoagulants does reduce the risk of VTE in certain patients, but it makes them bleed more. Jumping ahead to our patient who already had a thrombosis, we know, going back to the clot NEJM study in 2003, that we knew that we've been using low molecular weight heparins over Coumadin for ages, for about 2 decades, because the clot NEJM trial told us that low molecular weight heparins are superior to Coumadin. And we know from the sub-studies of our DOACs that NOACs are probably superior to Coumadin. But the question then came, what about low molecular weight heparins pitched against the NOACs? And we only, till 2015, had only a meta-analysis. And then lo and behold, in the last 2 years, we've had 4 randomized control trials pitting our favorite DOACs against low molecular weight heparins and a meta-analysis. And so let me go through them for this. That we have the SELECTI, which studied rivaroxaban against dalteparin. And across the board, whether we were studying rivaroxaban, edoxaban, or apixaban, luckily they were all compared against the same low molecular weight heparin, dalteparin, the risk of recurrent VTE was lower in the DOAC arm across the board. But here's a caveat. It does make us bleed more. And really, so if we have to compare, yes, dalteparin will have more recurrent VTE and the DOACs win out there. The risk of major bleeding is probably the same with a non-significant p-value, seeing both our 4 trials. But the risk of clinically relevant non-major bleeding is higher in DOACs, especially GI and GU bleeding. So going back to my previous slide, my drug of choice, if I'm choosing it for VTE, I usually tend to use apixaban, which probably has the best recurrent VTE profile and the best bleeding profile compared to rivaroxaban, which especially makes you bleed if you have GI cancers. And so also remember that not only should you pick the right DOAC, you should also make sure, again, make sure that there's no drug-to-drug interaction. So you cannot use either rivaroxaban or apixaban in patients such as for those with prostate cancer undergoing enzalutamide, because you will then have to change it to either edoxaban or dabigatran because they will have drug interaction. Or a lot of your cancer patients are going to have an angiotube or a PEG tube. Remember, you can't crush dabigatran. You can crush your rivaroxaban and apixaban, you can't crush dabigatran. So be careful with drug interactions, crushing, pharmacodynamics, and pharmacokinetics, especially in your cancer patients. And in our patient, we anticoagulated. For any catheter-related VTE, you have to anticoagulate them for 3 months or as long as the port is in place. I'm going to jump ahead with chemotherapy causing a whole slew of arrhythmias, including SVTs, bradycardia. Again, your micromedics becomes very important. Do not jump to putting in pacemakers on your cancer patients undergoing chemotherapy. Please look up the fact that maybe the chemotherapy is causing it, and you might just have a simple solution as stopping the chemotherapy and reversing the bradycardia. A lot of the chemo, especially arsenic, is notorious, and a lot of TKIs are notorious for causing QT prolongation and need a weekly EKG. But I'm going to jump ahead to chemo causing atrial fibrillation, especially in our cancer patients, because I know we use a lot of Chadvasc and Hasblood, but remember, as I said with our MI patients, our cancer patients, not only do they clot more, they bleed more. So the conventional risk scores that we use for atrial fibrillation are probably not relevant in our cancer patients. And we, of course, extrapolate the use of DOACs to our cancer patients from our sub-studies with edoxaban and rivaroxaban. But here is the one single drug, if for atrial fibrillation I want you to take home, is when you see any of your cancer patients on this guy called ibrutinib. Just remember my photo of Dr. Jekyll and Hyde. It's a great drug for our CML patients and a really lifesaver for them. But here's the part why I call it, Mr. Hyde, because the Mr. Hyde part of it causes atrial fibrillation of up to 16% by year 2. And remember, ibrutinib in our CML patients is used for years. And not just does it cause atrial fibrillation, it also causes severe thrombocytopenia and platelet dysfunction, which means it makes them bleed, which means if I'm using DOACs in these patients to anticoagulate them, it creates a clinical conundrum, because not only is it making them clot from AFib, it's also going to make them bleed. Plus, it has a whole lot of drug interactions with amiodarone, with diltiazem, with warfarin, with DAPT. And so you can use NOAC such as rivaroxaban and apixaban, but you have to probably adjust either the dose of the NOAC or adjust the dose of the ibrutinib and do a risk-benefit analysis with your oncology colleagues. And ending with cardiac emergencies, I'm going to end with this horrible echocardiogram of this patient who is undergoing treatment for angiosarcoma of the liver. And you can see that this black shadow, this echo face is not a good thing, because not only do we see it's a large amount of pericardial effusion, almost amounting to tamponade, but if you concentrate here on the right ventricle, so this is the left ventricle, the mitral valve, and the aortic valve here, the left ventricle seems to be nice and vigorous, but look at the right ventricle. There's a whole lot of gunk here. It doesn't have the blood that the LV cavity has, a whole lot of gunk here, and a thinned out RV wall where I'm pointing out there, and you're kind of wondering, oh my God, has the cancer, the angiosarcoma of the liver, has it spread to the RV? And is this an impending rupture of the right ventricular free wall from the metastatic cancer? And so we answered that question by giving contrast to the patient, and luckily the contrast did not extravasate into the pericardial space. So this was not an impending rupture, but this patient was sitting on a huge pericardial effusion here. And so the question here becomes a big problem, because the patient's platelet count, if you see down there, is 21,000. So I know I have to tap this huge pericardial effusion. So the question is, can we tap this? And when we call cardiology, what will the cardiology consult say? Can we safely do a pericardiocentesis in patients with thrombocytopenia, right? And should we just do a pericardiocentesis, or should we leave a drain in? And do these echo findings impact the survival of this patient? And luckily, we have data from MD Anderson, and this is actually a beautifully done, following up a study, a cohort of 45 patients, all with cancer, that were followed up with pericardial effusion. And 13 of them had big enough pericardial effusions to undergo pericardiocentesis. And believe it or not, it did not matter whether your platelet count was more or less than 50,000. Majority, 99% of them, tolerated a pericardiocentesis, irrespective of thrombocytopenia, as long as you were infusing platelets at the time of your pericardiocentesis. And it was safe to use as a primary treatment provided you left a drain in. So patients who had a pericardial drain left in them for 3 to 5 days had the lowest recurrence rate. If you just tap them and leave them alone, most likely they will reaccumulate. And lung cancer patients have probably the worst prognosis if they develop pericardial effusion or tamponade. And also remember, it's not just cancer causing pericardial effusion and tamponade, a whole slew of chemo causes it as well. So have that in the back of your mind when you're treating these patients, when you do not want to re-challenge them with chemo that might cause pericardial effusion. The top one being cyclophosphamide that causes hemorrhagic pericarditis and pericardial effusion. So we've been running cardio-oncology at Mount Sinai since 2013. Me with a lot of residents and fellows have written a lot of book chapters on cardio-oncology. There's no paucity of guidelines. There's none from ACC/AHA yet, but there's a dedicated journal on cardio-oncology. There are 8 fellowships across the country. And there's always need to be had as a resource, referral to specialists. I specialize in referrals to specialists, and I welcome all questions. You can put them in the chat box below, and happy to answer any questions that the audience and faculty might have, and hopefully leave you feeling a little bit more fortified when you're seeing inpatient consults in your cancer patients.
Well, thank you for this, Dr. Sahni. This was excellent, a whirlwind tour of a bunch of new material, so I really appreciate it. We have about 3 minutes, so maybe we'll take one question from the audience if there's somebody who wants to unmute and ask something.
Sure. So I know it's going to be online, and that's why I left the list of chemo and cardio that causes all the side effects, because I know that would be like a resource to sort of keep as a snapshot when you're doing consults. But again, as I said, in cancer patients, just look up the drug. Just go to your UpToDate or your Micromedics and look up the effects, and then feel free. I get a lot of email consults from you guys as well. Feel free. Even when I'm on vacation, I'm constantly answering my emails. And so the key point is that we are here to facilitate the job of our oncology colleagues and to let them get the treatment that our cancer patients need in a timely fashion. Our job is not to interrupt therapy, but to facilitate therapy in the safest way possible. So let me know, when you come across any of cardio-oncology conundrums. I can see them, via video visit. I can help you in your visits and your consults as inpatient. And of course, very happy to see them in person uptown as well.
Great. All right. Well, sounds like a good place to stop. Thank you so much, Dr. Sahni. Really appreciate it.